professionals that Professor Ocheng has enumerated there, it's quite a process, and it's adding to all these costs. What is the biggest strategy to ensure that, yes, we may have more centers, but they'll also be having the HRH that they require to work?
Well, thank you, Sam, and thank you, Madam Waziri and my colleagues. I think this issue of cost, to me, the biggest cost we have in cancer is loss of life. These other costs that we are working on reducing are possible, they are manageable. National Cancer Institute of Kenya is currently implementing a sector cancer strategy, which was developed by many stakeholders, and it's looking at from prevention. That is a strategy that we are using to slay this dragon. You know, our pillar number one is prevention and early detection. This is where the, primary health care, community health, this is where UHC is really anchored. When we talk about community health promoters, we really want to equip. In fact, in the next 2 weeks, we will be having community health promoters represented by PCN. They will be undergoing a 2-day well-structured curriculum on cancer messaging, and this is going to equip them on basic information that will allow them, be able to educate those who are in their community health units. We have our second pillar, which is, diagnosis using pathology, imaging, and radiology, and laboratory medicine in general. If you look at this team, it requires a lot of human resource, as Dr. Cheng has enumerated. And what we are doing, Governor Mudomi, we are changing our strategy now of training healthcare workers to avoid getting them out of the counties. We are discussing a proposal where we are going through the collegiate kind of training, where if you have a specialist in your institution, we do not need to get away your medical officer. But then we can attach this medical officer to University of Nairobi, and they will be doing didactics, but their clinical experience will be done within the institution, in the county governments. And we will not deprive you as a county this doctor who would still train under the mentorship of an experienced, doctor, a specialist for that matter. And not only in oncology, in surgery, in, radiology, in gynecology and obstetrics. And that will also cure the problem that you have replacing medical officers again and again. And you replace them, and sometimes they go for training and they never come back, unfortunately. So our pillar number 2 looks at this. And as we discussed the cost of cancer care, let me talk about, this one, and the third pillar, which is treatment, with curative or palliative intention and survivorship. There is a lot of infrastructural investment here that goes into increasing that cost of cancer care. If you look at radiotherapy machine, to put up one center, it costs 600 million. To put one basic comprehensive center without putting in a lot of investment, which would be ideal, especially at this level when technology has really changed practice and has been used to improve quality of care, to make sure side effects are less and to make sure there's precision oncology. When we talk about CyberKnife, we are talking about 750 million investment going into, treatment that has, precision oncology, where we are treating patients to as close as 1 millimeter. I do not want to go into the details of science here, but then the cost of investment in this, for us to have, to sustain these services, including maintenance, for us to sustain these services, we definitely would have, it comes with a cost. If you look at targeted therapies, and right now to treat cancer, we are also modulating the immunity. We are doing what we call immuno-oncology. You get one drug, every 3 weeks it's costing 850,000 shillings. Who can afford that for life or until death or until progression of the disease? So treatment, diagnostic, there is a lot of investment. When we look at the cost, and we are happy at least social health authorities stepping in to support in full. And I agree with Madam Waziri that we have to pay. We have to ask Kenyans to contribute. We have to be responsible for our health. If there is any taxes that are, returns are almost, it is this one. As much as all them are important because it contributes into quality of healthcare in general. Pillar number 4 that we are looking at as our strategy from the sector that we are implementing is on advocacy, coordination, partnership, and healthcare financing. And this is relevant at this point. We have to get resources. Our strategy is cost at 49 billion over the next 5 years. And for us to be able to implement this strategy to the latter, we need resources. And this is where now we are bringing together all stakeholders, government, non-government, state, non-state actors, including pharmaceutical companies who are also reaping heavily, in treatment. We are currently working with Roche, for instance. They have, programs, Roche and AstraZeneca. They have programs that are actually, we call them access programs, accepting a drug that could, Kenyans could not afford. Affordable. Right now, they are getting it at 33,000. When it came into market, Dr. Ocheng and Dr. Busakala and us who've been in the practice for quite a while, when we started our practice, nobody could afford that drug because we are looking at 500,000 shillings. But right now it is at 33,000 and it is covered by NHIF comprehensively. It's a life-saving drug. And we are looking at treatments for lung cancer, which these pharmaceuticals have subsidized, and also prostate cancer. So we are having that discussion to make sure that anybody who is investing in cancer care, we can cost and know it's going to reduce this. And we are engaging into more access programs. That is the direction. It's one of the strategies, as we also do pooled procurement for cancer drugs. Very important, because when we, economies of scale would